Morning everyone, I'm Holly Doyle. I'm an advanced physiotherapy practitioner at Cambridge University Hospitals. So I work part-time in the NHS, mostly with young adult hip patients, and then I work privately, treating people all over the world under my private business, which is Hip Dysplasia Physio. I also do lots of online rehab advice on my Hip Dysplasia Physio Instagram. And then I have a little alternative business, which is I did a vet masters and I treat lovely doggies.
Perfect. The next question is, what led you to become a hip specialist physiotherapist, and what is your favourite part about your job?
So I think what led me to become a hip specialist physio is a combination of factors. So I always wanted to do sports physiotherapy when I qualified, and I did lots of time within elite sport. Developed a kind of love for hip pathology then. And then when I was 24, I got diagnosed with hip dysplasia myself. That probably also helped me decide, I think you go one of two ways. You either decide that you're going to love the pathology you have or hate it. I realised that lots of people don't really know how to treat dysplasia, and I had to fight quite a lot for my own management, and so I decided that I would kind of see how I can help others go through what I've been through, and give advice both from a professional side and from a patient side. And I really enjoyed being able to help people and have that knowledge that I'm not just quoting you research, I've done it myself, basically.
Perfect. Next question is, have you found that your personal experience with dysplasia influences how you treat your patients?
Definitely, yeah. So dysplasia sadly hasn't got lots of evidence-based practice and research around rehab and conservative or post-op management. And I don't, obviously, people, because of what I put out there, may know that I have dysplasia, but I don't always, especially in my NHS practice, like tell my patients or say anything. I try and judge whether I feel that it will be beneficial to let them know that I understand and that these are the things that I've experienced. And especially when you're saying, you know, you can make things become not painful anymore, you can get strong, you can do, because I think a lot of the medical professional world constantly tells us what we can't do. And I like to be able to tell people it can be done, you can get strong, you can manage this conservatively, you can get through the operation. So I think it really influences my positivity and drive for not just having read a piece of research that tells us that 50 people have done it. I've done it. It doesn't mean that you're going to be limited by someone saying you shouldn't or can't do this.
Yeah, sounds good. Next question is regarding conservative management for dysplasia. What do you focus on?
So the most important thing as a starting point for conservative management, in my opinion, is understanding your anatomy and what positions are going to aggravate your pain and what positions are going to ease your pain. So it can be as simple as just changing the way you squat, rotating your hips one way, just understanding that complex anatomy of your femur and your socket, and your physio should be able to help you with that. So they might say, for example, if you're retroverted in the femur, then you want to squat with your feet externally rotated so that you're not loading into that internal rotation. So you wouldn't want to do a straight squat, for example. And then just education and understanding of the pathology, understanding what's going on in the hip and why, and what we can do. So the first port of call, the muscles are the most important part, because when you've got dysplasia, up to 50% of patients have hypermobility alongside that. And then that means that there's compromise of the passive stabilizers of the hip and pelvis. So the bones aren't in perfect alignment. The ligaments and the capsule are lax, which we will see if you have got that hypermobility. And then the only thing that is helping to stabilize the hip is therefore your active stability system, so your muscles. So the stronger those muscles are, the more those bones are going to be supported, and the less you're going to rely on those lax ligaments if you have that hypermobility. So obviously it's very difficult when you've got pain to try and start loading and understand. But if you understand how to load correctly, you can get the strength, and that's through the whole kinetic chain. So strengthening all of the lower limb, including your calf muscles, which is really, really important for generating that force for your toe off. You need to progress through double leg loading, step stance loading, and then into single leg loading, because we all need to understand that to walk, for example, or climb a step, that is balancing on one leg, it's pushing up on one leg. Climbing a step is doing a single leg squat. So if you haven't got good control and you haven't got the strength to push whatever you weigh, your body weight, on one leg, then you will overload that area where you've got pathology, aka the dysplasia. Core stability is really, really important. So having strong trunk muscles and deep core muscles, that really helps with that lumbopelvic control. And then just being kind to yourself, setting goals, understanding you'll have setbacks, knowing that what to work with, what exercises you should be doing. Once you have a diagnosis of dysplasia, it's really important that you know that you kind of need to manage this long term. And it's not just, oh, I can do my exercises for 6 weeks and then it's done. And I think if you have those goals and your physio helps you to understand and see where your strength is lacking, and you can see those changes, then you'll see huge improvements. There isn't any evidence in terms of a paper that I can prove this on, but it's the thing that I really think makes the difference, which is the unstable surface work, the proprioceptive work. So the deep muscles that are closest to the joint, they're the ones that attach to the capsule, and they provide that proprioceptive stability. So that's the understanding of where your joint is in space. So if we've got altered shearing going on in the joint because we've got lack of stability, those muscles are like your natural corset. So working on unstable surfaces, those muscles are having to work all the time and switch on and off, and we can start working those deep stabilizers. And I really think it's something I want to prove in the future, but I really think working on BOSU or wobble cushions, anything there is going to really help with that proprioceptive stability, the activation of the deep stabilizers. And that's what I think personally has made a massive difference for me. So you'll always see me on an unstable surface on lots of my rehab.
And the next question is, what advice would you give patients who are awaiting surgery?
So if you're awaiting surgery, the stronger you are going into any surgery, the better and quicker you're going to recover coming out. So again, understanding your anatomy, working with your physio, setting your goals for what you want to achieve pre-surgery, building up that strength, so looking at your double and single leg strength, strengthening that core. And I think read around the subject, understand kind of what the post-op rehab is going to involve, because as I said, the stronger you are before, the faster you're going to recover afterwards. So muscles take a long time to build up. It takes 6 weeks to see significant strength changes in muscle, but it takes a few days for them to waste away. And when you've had the PAO, you're not able to do a lot in the first few weeks. So those muscles can reduce quite quickly. So the stronger you are, the faster they're going to recover after the operation. I think be vigilant and speaking with, people who have had it, people who have been through it and are going through it. Obviously, there's lots of information on the Facebook pages, and it's very useful to kind of get a setting and goal set for you for what you want to understand, you want to return to, what you want to return to work-wise, what your plans are with work, who's going to support you family-wise, because you will need help in those first few weeks. So that's really key, is just setting all your plans up and understanding what that procedure is going to involve and the rehab. Yeah, I think that's probably it. Have real trust in your surgeon, and what the plan is for your rehab and where you're going to get it afterwards as well.
The next question is regarding PAO recovery. Could you give a rough overview of post-operative rehab protocols and anticipated timelines for returning to various activities such as work or driving?
Okay, so after PAO, patients are quite often, again, there will be slight alternatives between different surgeons, but after para-SW osteotomy, normally you're about 20% weight bearing, so on the operated side. So you'll be on crutches, and you're on those, again, it will differ between surgeons, but some surgeons will scan at 6 weeks and some surgeons will scan at 8, but you'll be on those crutches for that time until you have that scan done. So within that period, we want to start working on controlling of your swelling, regaining range of motion, getting some isometric, so that static contractions going of the muscles, working you in unloaded positions, but you don't want to force flexion past 90, regaining that core stability, and you can do some prone lying to get a little stretch in the front of the hip after the swelling. The most important thing is that you don't completely non-weight bear, because if you do non-weight bear the leg and you suspend it, rather than putting that tiny bit of weight that you're allowed through it, it changes and accelerates proteoglycan degradation, and that can change, because of the suspension, it changes the force on the femur and on the hip flexor unit. So you actually end up with more hip flexor issues if you completely non-weight beared because of the weight. Okay, so that's really important. Hydrotherapy in those early stages is the best thing ever, because you can get in the pool chest level, you can walk, you can move, you can squat, you can do everything, and that gets you really using the joint and the muscles, but in an unloaded environment. If your physio unit has a anti-gravity treadmill, again, utterly amazing. They can set you at 80%, almost like you're walking on the moon. But again, you can start loading all the tissues in the body without overloading the bone and keeping within those restrictions. If it depends on what you want work-wise. So if you're in an office-based job, you could push yourself and go back at 2 weeks. It obviously depends on, you know, your sick leave policies and where your goals are set at. In terms of the management, I would very much recommend that, you know, you do make sure, if you're desperate to go back to work, you do keep time for you to be doing your rehab as well, because it's a lot to recover from. So office-based work, 2 to 6 weeks, 2 if you're pushing yourself, 6 weeks, ideally you could go back. Once you get that x-ray at 6 or 8 weeks, once they see that there's good healing going on in the bone and in the cuts that they've made, then we will start the progressive weight bearing. So the next stage after that x-ray is starting to then go to 50% weight bearing. And then again, timelines will differ, but then again, you might have an x-ray at 12 weeks to check that everything has healed. And that's when you will end up then going to full weight bearing. So if you're back to work in a more manual job, like working in a hospital, being a physio, whatever, on your feet all day, it's going to take you that little bit longer to get back to your work. So it's more likely going to be 4 to 6 months before you can start a graded return. And you would want to make sure that if you have, and you work in a big company, an Occi Health department, and that you're going back, you know, a couple of hours every other day and then building that up over 6 weeks. You want to make sure that you're staying on your crutches and you're keeping good control up until the point that you go to full weight bearing. But even then, your physio may keep you on one crutch because you don't want to see that you're lurching over when you're trying to walk. You want to get that correctness and that single leg strength back before you completely lose the crutches. So don't be under a real fight. And sometimes you hear people come in and say, oh, you know, you shouldn't be on a crutch now. But if your physio's kept you on, that's absolutely fine. It's just because of your muscles just taking that little bit longer to support your body weight. And that again harks back to, if you're weaker before the operation and you have a lot of altered movement patterns, we know from the research that the muscles that are deepest are the ones that waste away when you have pathology. And so it's going to take you longer post the operation to really get those kicking in and working correctly for you. So you may notice that you're tilting for longer and you're kept on a crutch for longer. Okay. So that second stage is progressing through that weight bearing from 50% up to 100% of weight bearing. And then your physio will start you into double leg loading position, because that's 50-50. So you'd be allowed to bridge, squat, again, working the pull, but at waist height instead of chest. Double leg heel raise on land. So that's all 50-50. And then you want to progress through strengthening the muscles within that range and gradually build up. And when you get the go ahead for full weight bearing at the 12-week mark, then we can progress to starting some step stance rehab. And you want to identify the muscle groups that maybe are whittled away before the operation and need a little bit more input. You want to identify strength deficits between the unoperated side and the operated side, and we want to try and build back to that same strength. Then once you're on that full weight bearing, you progress through the double step stance to single leg weight bearing. Then we can start to look at that kind of return to sport and return to what you want to be able to do and what you need out of your hip. So that often happens at about the 6-month mark. Okay.
Right. And do any patient characteristics impact these guidelines?
So in terms of post-operative or pre-op, what we're looking at is there any arthritis in the joint? If there's too severe arthritis, so there's a grading system. If you overgrade 2 to 4 in the arthritis grading system, then they will be hesitant to do the operation. The reason being is that if there's already arthritis in the joint and quite severe arthritis, then that hip preservation surgery is a lot to go through for the joint to maybe not last that long, because the arthritis is already there quite significantly. They will also look at age. So very much differs in the research, but some surgeons won't want to operate on patients over 40, again, just because there's more complexities, higher risks. But there are studies that show that patients over 40 do well with a PAO if they don't have arthritis. So that's for a discussion with your surgeon. BMI, again, needs to be under 30 to be able to perform the PAO surgery. And that's because there are several studies that show there are more risks and risks of complications in patients that have a higher BMI. And then smoking. So if you smoke, there is a higher risk of non-union. So where they've performed the cuts and that bone needs to heal, smoking has shown that it basically delays bony healing, and you can end up with non-unions in those cuts. And that would then result in you having months and months on crutches, and in some cases, some cuts never heal. So if you smoke, definitely try and quit with some help from your doctor. If you can manage to go cold turkey, brilliant. But if you can cut down significantly, but some surgeons aren't willing to operate. But therefore, post-operatively, what we're looking at, again, if you have a higher BMI, then it's just going to take you longer for those muscles to be able to push. It doesn't really matter what we weigh, it's can our muscles push that body weight for us. So that's what I always say to my patients. It doesn't matter if you're 60 or 160 kilos, our legs just need to be able to push it to support our joints. So obviously it's going to take longer to build back up to being able to push higher body weight. And then if you're smoking or have been a smoker, we want to monitor your healing very carefully. And that may mean that you are delayed slightly and pulled back on those progressions of weight bearing statuses as we go through those sort of 6 and 12 week scans. But I think, we can all work together as an MDT and help you in all realms of that, because, lots of people have been in pain for years and years and it hasn't been discovered, and BMI might have creeped up. And so therefore it's kind of that catch-22 of how can I exercise, what can I do? And that's what your physio can help you with, to help you reduce that BMI to be a candidate for surgery.
The next question is, how do you find that many patients return to sport after PAO, and how do you approach return to sport for these patients?
Yeah, absolutely. We can get patients back to most sports, pretty much anything. That's the reason why we have this surgery. Then there's no point in going through this if you can't do what you want to do and get what you want out of your hip. So once you've met certain guidelines, and normally it's around the 6-month mark, then we can start looking at kind of return to sport protocol. So there aren't any guidelines, unlike, for example, an ACL. If you've done an anterior cruciate, there's specific guidelines in return to sport. So I've kind of adapted some, and we're working on it in terms of what we can do post-hip surgery. But you want to be able to look at the forces. So you want to be able to do plyometric rehab, so that's jumping, hopping. You want to look at triple hop for distance. You want to look at squat depth. You want your abductor ratio to be 75 to 80% of the other side. So that's in terms of strength. I also like to look at single leg press. Again, if depending on how you run, you can take up to 5 times your body weight in ground reaction forces through the joints as you're running. So you definitely need to be able to push up to 1.5 times your body weight single leg if you want to run. Then we need to add in, if you want to play a rotational sport, we need to add in multi-directional rotational rehab under load, and then sport-specific drills. And then you would start building up the endurance, whether you're running or time, in training, time on the pitch. You wouldn't just go straight back into it. Many patients return, and many patients return at a high level. Those that are in elite sport, some patients don't quite get back to full capacity for their elite sport. I think there was a study, and it said of 70 patients in elite sport, 20% didn't quite get back to that level. But, it can be done. We can get you there with the right rehab.
Perfect. And could you expand on common issues experienced after PAO and how you approach them with physiotherapy?
So a lot of the issues that we see are driven by, as I said, what we see pre-op as well, where you've got those weaknesses and altered mechanics and altered muscle patterning. We see that because of the wasting away of those deeper muscles, the more superficial muscles take over and they're cheating. And we also learn to move our bodies in certain ways to be able to move around, and that can kind of carry on after the operation. So that's why it's quite key in that first 6-week period to be able to have your physio kind of identify and wake up those muscle groups that are more important, the deeper ones, working the core stability. We do often see a lot of gluteal tendinopathies post-operation, a lot of hip flexor pathology, and psoas irritation. So we want to be ensuring that we can focus on why that's happening and what we can do to help it. So is it that it's a learned behaviour from pre-op? Is it that there's overload from pre-op as well, because psoas is a garter? Is it the positioning and the change of the anatomy that they've done from the surgery? So there's lots of different reasons why it can happen. But what we would want to do is explain and look at strength, control, all of the muscle groups, and understand why you were maybe getting a gluteal tendinopathy or a psoas tendinopathy. So you can work on never stretch the hip flexors, because stretching and compression is quite a component of tendinopathy. So we want to create length and do that by loading what we call eccentrically, so under length. There was a recent consensus from the North American group, and we want to make sure that we don't do kind of straight leg raise work. We should never do for at least 6 weeks, was the original thought process. But the consensus that's come out of North America has pushed that to 8 weeks. The reason being is it's straight leg raise and lifting your leg up in the air. Whilst it seems like a really simple exercise, it's again up to 5 times your body weight shearing through the pelvis. So it's huge forces. So we definitely don't want to be doing any of that within those first 8 weeks. And then we want to start short lever loading of the hip flexor unit after then, rather than going straight for your straight leg raises, because it's such forces. We want to make sure that we're rehabbing all of the muscle groups. So during the operation, they have to reflect quite a lot of muscles around the pelvis and around the trunk. So there's quite often a lot of issues that can come from obliques and trunk strength, and that can affect single leg stability, and that can be why you develop that hip flexor issue or gluteal tendinopathy. So we want to make sure that we're rehabbing your trunk and core muscles. Ronna's favourite exercise.
Pass.
But yeah, any complication that we get, the other things are mostly, there are risks of stress fractures, there are risks of non-unions, as we've spoken about already. But it's just making sure that you feed that back, that things aren't quite right for you, to your team, and then we can listen and investigate and work out exactly what's going on.
Perfect. And the next question is, what area would you like to see developed through research for hip dysplasia?
Oh, there's so much. So I think we need a consensus on diagnosis. We need a consensus on post-op rehab, a consensus on conservative rehab. I want to see development of, obviously, the difference that I think that proprioceptive rehab can make in this population. I think the big thing that needs to change, the study that I always talk about is Nunley's from 2011, and the fact that it takes 5 years on average to diagnosis, having seen 3.5 clinicians. And I think one of the big things that has to change is just awareness from the bottom up. So that includes awareness in GPs, awareness in radiologists, awareness in physios, chiropractors. It needs to be taught at university. And I think, a lot of scans are often reported as normal. And, if you know what dysplasia is and you then review the scan, and that might be 3 years later, but you look at that scan and you can clearly see dysplasia and it just wasn't commented on. So I think to change a patient's pathway, the most important thing for the patient is that you get an early diagnosis, so we don't get all these comments of, oh, it's in your head and it's growing pains. And, so many patients I see have had such an awful journey to get to just the diagnosis, and that really affects us mentally, physically. We can capture that diagnosis early on, raise awareness, the patient's in a much better space. That would be my dream, that we can change that for patients going forwards. And then, we can get more improvement with conservative options and go from there.
Perfect. Sounds like a very good aim. And the last question is, what resources would you direct patients to? So you have your own Instagram and stuff and your booklet. Could you talk a bit about that?
So yeah, another wonderful physio, MJ Sharp, who people might know. She has also had a PAO. I think a Birmingham one, like you. And we have talked lots, and then she came up with a wonderful idea of developing a leaflet, and then we worked together and built this leaflet. This leaflet started tiny, and then we decided to make it into a research project. So some of you may have been involved, and she surveyed the patients, and then I surveyed the clinicians, and we were looking at, what patients' understanding from their letters was and what their understanding of their appointments was. And basically it came out that you go to this appointment, it's taken all this time to diagnosis, and then you get this letter that's got loads of big words in and none of us understand it. So we developed this leaflet to try and take you through what dysplasia is, why you have it, what are the factors that are involved in it, what are the other pathologies that link with it, what's the management, trying to just develop that so that when you come out of that initial appointment and it's kind of hit you with the shock and all these big words and these big letters, you can see on the leaflet, oh, the letter from the consultant says X, I can see that that angle means this and this means that, and you can really piece it all together. And then these are the options for surgery, this is the option for conservative management, and you've got it all there in one unit. So that's up on my hip dysplasia physio website. It's also up on the RNOH, that's Stanmore's patient information page. But it's used all over the world now to help people understand their dysplasia. So MJ and I are very happy and very proud of that. And I hope it's helped some of you. And then, yes, I have an Instagram page, Hip Dysplasia Physio, and I try and do little tips and tricks and talk about dysplasia on there. Happy to talk to any of you anytime, so just send me a message, any questions that you may have. I've had a 1-year-old, so it's a little bit less used than normal, or not as often posted on as I should. But yeah, I try and post blogs and latest research and just keep you all up to date. That's both for clinicians or for patients. Happy to chat through anything. If there's anything on there you see, just drop me a message.
Perfect. That's lots of information for everyone to think through. So thank you very much for your time, Holly. And we'll put the information in for anyone to contact Holly if they want.